Welcome, everyone. We have a very special speaker today. We have Dr. Sue Borson, who's part of our university system. And I asked her to send me some information about herself. And I can't possibly edit it down because everything she says is so important and so vital and so meaningful. And it's just a wonderful description of who she is and what she's doing. So I'm starting absolutely on time today to be able to get the introduction in. Sue Borson is professor of psychiatry and adjunct professor of psychosocial and community nursing at UW. She directs the Memory Disorders Clinic here, where she teaches residents in psychiatry and neurology, fellows in geriatric psychiatry and medicine, and graduate nursing students. Dr. Borson is an honors graduate of Stanford School of Medicine and of the UW's psychiatric and geropsych residency programs, and is a fellow of the Hedwig von Amergen Executive Leadership Program in Academic Medicine. She has been a core investigator in the Alzheimer's Disease Research Center, chair of the NIMH Mental Disorders of Aging Initial Review Group, president of the American Association for Geriatric Psychiatry, and a fellow of the American Psychiatric Association and Gerontological Society of America. She is associate editor for neuropsychiatry of the Journal of the American Geriatric Society. She serves on United Healthcare's Medicare and Retirement Professional Advisory Board. This fall, she was named by U.S. News and World Report among the top 1% of U.S. physicians. Dr. Borson has received research funding from the VA Research Service, National Institute on Aging, NIMH, and National Heart, Lung, and Blood Institute. She conducted a randomized trial of dementia screening in primary care in UW neighborhood clinics, and has co-authored the 2012 Alzheimer's Association recommendations for cognitive assessment in CMS's new Medicare annual wellness visit for seniors, and the AMA practice-based measures of dementia care quality. She created and validated the mini-cog for identification of cognitive impairment in non-specialist environments. This screening test is now being used throughout the U.S. and was recently endorsed by the Alzheimer's Association and National Institute on Aging as a preferred screening tool for primary care. She has also developed a screening method for finding and managing high-needs dementia dyads and is now working collaboratively on measure of caregiver activation for dementia interventions in healthcare settings. Dr. Borson has published 230 peer-reviewed papers, abstract and book chapters, focusing on the psychiatry of chronic disease, the clinical neuroscience of dementias, and the case for improving diagnosis and integrated care for persons with late-life cognitive disorders and their family caregivers. Dr. Borson, a pleasure to have you speak with us.
Thank you very much. All it really takes is you get old enough and all that stuff builds up. So I want to talk to you today about something that is very, very, very dear to my heart. Let me start by saying that in 1997, the first reasonably effective drugs to treat dementia, especially Alzheimer's disease, were introduced. And at that point, a long-running service called Geriatric and Family Services Clinic, which had started 20 years before that to learn something about clinical management of patients with dementia. At that point, leadership needed to be transitioned to a physician. And at that point, I was offered the leadership role for that clinic because now we had a medical treatment and it was time to start prescribing. That was a time of incredible excitement. We thought that Aricept and the drugs like Aricept and then subsequently Memantine or Namenda really just heralded a new era in biomedical treatment of neurodegenerative brain disease. I myself was totally convinced that what we needed to do was support neurons, give them growth factors, help them to resist the insidious decline that is associated with aging and with neurodegenerative diseases that we that we can name, like Parkinson's disease and Alzheimer's disease. So the concept at the time, in the mid and late 90s, was that we were on the verge of a completely new era in the management of fatal brain disease. None of that happened. And after many, many years of various kinds of clinical trials and drug development and transgenic mouse models and a variety of other experimental interventions, we've learned a lot about the basic pathophysiology of neurons and of brain diseases. We know a lot about it in mice. We know a lot more about it now in people. But the one most promising hypothesis, which was if you can keep amyloid, sticky, icky protein that damages synapses and kills neurons ultimately, at least according to what we think from the lab, if you can get rid of that stuff, you've got it killed. So now that we have several negative amyloid reduction trials in human beings where we know we can get rid of amyloid but we can't make the patient really better, the field has moved to a completely different model, which is you have to find people at high risk, and if you're going to do biological interventions, you have to do them far earlier than they ever present to clinical care. So just so that you know, along this line, NIH has now just funded a very important trial of Alzheimer's disease prevention in a small group of familial Alzheimer patients with dominant mutations that cause the disease and cause amyloid buildup. So this new trial will give us probably as close to a definitive test as we can get about of the leading hypothesis in pathogenesis of the disease, which is amyloid buildup. Well, so then what? We have negative trials and disappointing results, and we have an epidemic of Alzheimer's disease in our population. So what I'm going to talk to you about in the rest of this talk is what happened for me when I was asked to take on the Memory Disorders Clinic, become its director. The first thing that I had to do was figure out how the heck you manage patients with dementia. There was virtually no information about that except a lot of quasi-negative information about drug therapies for behavioral problems. But there was only a smattering of any realistic kind of understanding of what patient management is. For a number of reasons, I had always been very interested in chronic disease and what that means when a person has a chronic, incurable condition and how that impacts healthcare and the relationship of doctor and patient, the relationship of patient and family, the relationship of family to healthcare. So this has always been a deep interest of mine. I can't explain why it's been so, but it has been, and this was the absolutely perfect ground to work on questions like this. So, Eric Larson, who many of you know, former medical director at University of Washington Hospital and now head of Group Health Cooperatives Research Group, has had, from an internal medicine point of view, a great interest in dementia and has been running a very important trial on risk factors for dementia at Group Health for many, many years. You'll see some data that we analyzed from that trial later on in the talk. So Eric tells this story. A recent fellow and new faculty member said, "My 85-year-old grandma just fell and broke her hip. I need to go to Boston to make sure something doesn't go wrong." And Eric says, kindly, "That's really good of you. It's a wonderful thing to do. But think of what you just said. let me introduce you to Joe Bailey. Joe is an 82-year-old man who's lived alone for the last 3 years since his wife died. Joe and Mary were the grandparents of their whole neighborhood. Everybody loved them. Then several years before her death, Mary developed a very indolent cancer, which ultimately spread throughout her body and caused an agonizing, painful death. Joe was by her side the entire time. Once she had died, when he was about 79, of course he went into a kind of a different state of being. He missed her terribly. He was very sad. He didn't want to do much. His daughter Lori, who was going through troubles of her own at the time and missed her mother also, started to worry that maybe he was depressed, maybe he needed to have antidepressant therapy or see a counselor, but Joe didn't want to talk about it with his doctor. After all, his doctor was really busy, and he shouldn't bother his doctor with things like this. This is just what happens in life. You lose your spouse, and you go on living. Then a couple of years after that, Lori began to worry that maybe there was something else that was going on. She noticed that the fridge was often too empty, that maybe there were too many pills still left in the bottle. She just wasn't sure, and she thought he might have a memory problem. So she called his doctor and said that she was a bit concerned. She didn't have anything too specific to report, but she was worried that memory was failing. However, Joe, whenever he saw his doctor, he looked wonderful. He talked well. He was very pleasant. He smiled. He was very attached to his doctor. And he always assured the doctor that he did everything that he was supposed to be doing. In July of this year, however, his blood pressure was up. He'd had hypertension for a long time. Lisinopril had controlled it beautifully, but suddenly his blood pressure was higher now than it ever had been before. And the doctor said, we should do something about this. So he added hydrochlorothiazide, a reasonable step, actually. And then in late August, Lori called her dad, as she did every day, and for a couple of days he didn't pick up the phone. So she called the EMTs, who went to the house, got the door open, and found Joe lying on the kitchen floor in a dazed state. Joe didn't know quite where he was or how long he'd been down on the floor. He didn't know when he'd last had a meal or something to drink. And he did recognize Lori when she got there, but that was as far as it went. He was carefully taken with a blood pressure of 90/50 to the emergency room of our local hospital, where he had a workup that probably cost in the neighborhood of $10,000, the original workup. He was found to have a serious hip fracture and bad osteoarthritis of the hip on top of that. So he was taken to the OR after tuning him up enough to survive an operation. Following the operation and transfer from the recovery room to the orthopedics floor, he began to pull out his tubes. He was fighting with the nurses, and he said, "You're trying to kill me!" Psychiatry was called. So psychiatry made an accurate diagnosis of delirium and started him on haloperidol, 2 milligrams IV, every 6 hours. In 36 hours, Joe was a lot better. He wasn't pulling out his IVs anymore. But he was lying in bed, saying nothing. And when the psych consult came back, Joe said, "Just let me die." So, in summary, here's Joe with a fall and fracture, emergency room, hospitalization, delirium, surgery, and suicidal ideation. This is a story that is repeated hundreds of times in our emergency rooms, in every emergency room of every hospital around the country, in fact, around the world. Time and time again, Joe Bailey comes to see us. As I'm talking with you today, I want you to think about what was wrong. What did go wrong? And should we be looking at this as just one of those random events that happens to old people all the time? We know that statistically, lots of randomness in aging-related problems. Or was there something that if we thought about it differently, we could do differently and get a different result. I'm prompted to think about what, was it Freud who said, neurosis is continuing to do the things that don't work and expecting the outcome to be different next time? Something like that. Paraphrase. John Stewart, okay. A very good source, okay. So I want us to take a population health perspective on dementia at this point. So we all know, if you think about it, dementia is a terminal diagnosis. It is a scary concept, the idea that it's a terminal diagnosis, and it's not one that I normally use when I talk to people about dementia. What it really means is that dementia is a progressive, incurable condition in almost all cases. And if something doesn't kill you first, it will. So that's what it means. But for purposes of what we want to talk about now, dementia has some other effects that not everybody knows about or thinks about in quite this way. And that is that it masks, but at the same time increases the severity of many other conditions. Let's take the example of urinary tract infection. We found in our study using the Eric Larson's ACT data merged with group health hospitalization data that people with incident dementia who were just in a healthy population and then emerged with dementia over time had a 70% higher rate of preventable hospitalizations than people who never became demented. And one of the unique contributors to that increased rate was urinary tract infection. So for all the women in the audience, many of you will have already had a urinary tract infection, and you know what it feels like. It feels awful. It hurts. You don't want to pee. You got to pee. You got to keep peeing. You don't want to pee. You got to drink. You get to your doctor right away, usually the same day, and you get on treatment. You barely miss a day of work. But the old woman with Alzheimer's disease who gets a urinary tract infection simply gets kind of weak and bland, has no complaints referable to the urinary tract. She just doesn't feel very good in some way, and she doesn't want to eat or drink. And then she gets dehydrated, and then somebody says something maybe is wrong. So that's a kind of really classic example of how dementia both masks the symptoms of many other diseases, but then makes them worse by the time they come to clinical attention. So the patient is sicker by the time they're seen for something that could have been corrected much earlier. There's a lot of old data about, old and new, that people with dementia stay in hospitals longer, they have more complications, their nursing home stays are longer, and costs are enormous. The largest cost driver for dementia care, of course, is Medicaid for long-term care, and the second most costly aspect of care is hospitalizations for dementia. Recent data say that there are twice as many site of care transitions. What does that mean? It means from home to hospital for some acute problem, then hospital to a nursing home, then nursing home to home, then home to an adult family home, then back into the hospital, and so forth and so on. Those are site of care transitions. Twice as many for people with dementia. There's been a revolution, and it isn't the biomedical revolution that we all were wishing for in the mid-90s. The revolution is in the National Alzheimer's Plan. What is that? The National Alzheimer Project Act was passed in 2010, kind of in tandem with the Affordable Care Act. The National Alzheimer Plan has now evolved to the point where it's no longer just an act, but it's actually moving toward implementation of certain of its provisions. But there are three basic investment priorities for this plan. The first is in biomedical research. No surprise, this is the United States. And of course, biomedical research has to be funded federally because there are not other sources of funding. So $80 million are to go to biomedical research, which is mostly discovery research and clinical interventions for the disease process. Research on the delivery of health care is slated to get about $40 million, although allocations have not yet been made, unlike for biomedical research. Then long-term care and social support, which focuses on families, but so does Part 2, the health care spending, that gets $20 million. The key goals for healthcare now, and I'm focusing on healthcare, are to develop a dementia-capable workforce, timely and accurate diagnosis followed by education and support, consensus on how to deliver and how to measure the quality of care, safe and effective, and I would submit fewer care transitions for people who are demented, healthy, capable families. Now, hidden in that, of course, is the message that we want our families to keep the patients at home longer to save the costs of long-term care. And we have to be careful as clinicians that we don't buy in too much to that, because there are many people and many families who really need long-term care, and there isn't going to be a way to prevent that. And then we need new models of how to deliver care and how to coordinate the care that is delivered. Can we do it now? I mean, why can't we do it now? Can we? Well, we can objectively assess older adults for cognitive impairment. Yes, we can do that. We can diagnose dementia when it's present. We can find the cause. We can figure out the stage. We can assess the functional impact of dementia. We can do that. That's important. But can we provide dementia-specific, relevant, proactive, and comprehensive patient care? Well, in theory, we could. Well, then whose job would it be? Well, it would be people like me, geriatric psychiatrists who really love to work on dementia and work with families and patients and get a lot of enjoyment and sense of gratification from this. But if you look at the bottom line here, let's see if we can get the pointer. Can't get it. Okay. The bottom line here, that's the number of geriatric psychiatrists. You can see that the numbers are tiny and they're not growing. In fact, they're shrinking, and many programs around the country to train us are not filling. The next line up is geriatricians, geriatric medicine, people trained in geriatric medicine. You can see there too, although the numbers are greater, there's no trajectory of growth in this field. And the same problem with filling fellowships exists there. The red line on the top is the exponential growth of cases of Alzheimer's disease in the population. So isn't it pretty obvious that from numbers alone, we can't rely on the specialists to do the job? Oh, okay. There we go. Well, so that means generally primary care, doesn't it? So let's do a report on primary care. I've just defined some steps in the delivery of primary care here. These come from actually what it takes to deliver primary care for dementia. This is just the real stuff. This doesn't need to be supported by research per se, that these are the steps. But it is supported by research. So documenting cognitive impairment, open disclosure of the diagnosis and discussion of what it means, stage-appropriate long-range healthcare planning, and care coordination and collaboration. What we know about primary care is that we don't do a good job. And this is not to slam primary care providers. There are a lot of reasons for this. We could spend at least an hour or more talking about why this is true. But I think that one of the major reasons it's true is that primary care and our medical environment in general have always looked at diseases as things that we treat with drugs or surgery. That's what disease is. Dementia is not a very treatable disease when you think about it that way. So this is the quintessential long-term chronic care management condition. This is the condition for which the idea of chronic care management really could have been invented. And that is not what primary care providers typically do, nor is it typically what they can do on their own in this era of coalescing practice management as large corporations buy up more and more practices and then set norms for how practice is to be enacted. We need to be looking at the healthcare systems that are governing how we do the care we give. So these are the things that systems can do, quite separate from primary care providers as individuals. The first step is to decide to take on dementia care, to look at the cost of dementia care in human life, in suffering, in family stress, in dollars in utilization of healthcare services that don't work, etc., to decide to take it on and think seriously about it. Then there's detecting dementia in clinical populations, delivering clinically relevant chronic care, defining clinical pathways to serve people with extra high needs, to demonstrate the essential staffing patterns, because I can tell you it's not a doctor sitting in an office. That's not a staffing pattern that's going to work for dementia care. And then eventually, health systems have to demand realistic payment reforms that really look at what the job is. Of course, I wouldn't be here if I didn't think there were some solutions to problems like this. Let's come back to Joe Bailey. This is what we're so good at in American healthcare. We're great at picking out the piece of the puzzle that we can treat with surgery or with medications. We focus in on what the disease is, we treat it, and then we're good to go. But that's just one piece of the puzzle. Our job is to identify today the missing pieces in that picture on behalf of Joe Bailey and everyone like him throughout the world. And then to put those pieces together and say, how do we bring this about? And how do we turn this into something we can use? So over the last 15 years, that's what I've been thinking about. And this is what has come from that. That the essential components of delivering good dementia care over a long period of time has these 4 components. The first, in green, is diagnosis of what the problem is, staging it, assessing its impact on function. The second piece, in blue, is evaluating medical comorbidity and health and safety risks going forward that are unique to this person. The third part is neuropsychiatric symptom and syndrome assessment and management in the patient. And the last is focusing directly on caregivers as themselves a target of care, a focus of intervention, and the essential link between healthcare systems and patients with dementia. With a system like this, we could hope for much better outcomes for patients, families, and our healthcare systems at large. So think about Joe and think about this model. And as we come toward the end of my talk later on, we'll talk about how you might think of applying this and what impact that might have had on him. Okay, so I have to talk about the mini-cog because the mini-cog is the best thing I ever did. It's a dumb little test that takes very little time to do and works incredibly well to pick up dementia. It works as well as any other screening tool at much less than half the time. So it's really, I mean, who knew? Just as a little secret, I thought up the mini-cog one night about midnight, thinking about the problem of how do we screen people who are hard to screen? How do we screen people in a little bit of time instead of a lot of time? And how do we have a tool that would satisfy primary care doctors' needs to have something that can be given, preferably not even by them, but by somebody in their office with a little bit of training? So out of that and out of a good deal of data analysis on an existing data set we had developed came the idea that the mini-cog might be a tool that would really work. But for it to be useful, it has to do something besides pick up some arcane disease called Alzheimer's disease or Parkinson's dementia or something like that, because without effective treatments for these conditions, why should primary care want to do this? Well, I'll show you some of the reasons. These come from validation studies that we did and that were done by others. So the first validation was for dementia screening and detection. That was the primary goal. Worked pretty well. But now it picks up everyday disability. This was a population-based study that we did in Italy using home care workers as the data collectors. So they did the mini-cog and they did all kinds of assessments of comorbidities and functional status and so forth and so on. So mini-cog score was strongly associated with need for everyday assistance at home. Low health literacy, a study done by Lisa Chu at the VA during her VA Health Services fellowship many years ago. Risk of medication mismanagement at home, done by a group, several pharmacists that collaborated with us. Risk of delirium in hospitalized medical patients. The strongest risk factor for delirium was a failed minicog in patients with no history of dementia on their chart. Complications of elective surgery. This has been done by a surgical group. Length of hospital stay, post-op nursing home placement, risk of impaired driving, long-term mortality. So these are the kinds of things that speak to a healthcare system, I hope. As part of the Affordable Care Act, Medicare set up a new benefit called the annual wellness visit. This is a voluntary visit. You don't have to do it, but you can do it every year if you're in a health system that authorizes it or your doctor wants to do it and you say yes. So it has all these different components. It's extremely ambitious, unfortunately. When it was first developed, the top two were the really big ones. Detection of cognitive impairment using an objective, some kind of objective means, and a health risk assessment. What are the patient's diseases? This is broadly construed. What do we know about the patient's current health risks? Those were the two key components, and those are actually doable with a lot of other data to be collected at the same time. So there are incentives to participate in this. For patients, the incentive is you can spend nearly half an hour with your doctor without having to be sick. That's a pretty good incentive, and there's no copayment for these visits. For the doctor, the incentive is that you can actually get extra pay as a primary care doctor if you do this, and you can have people in your office who are not physicians, high-priced physicians, doing a lot of the assessment. So even then, certainly the minicog can be done that way by non-physicians, and much of the rest of it can be done by non-physicians too. It's the doctor's job to bring it all together. And when I say doctor, I don't mean to slight other kinds of primary care providers, such as nurse practitioners and others who function as primary care providers. Why don't we do that very much here in our system? Well, because there's no facility fee that is built in to the annual wellness visit. You can't charge a facility fee, and so that does not sit well with large systems that depend heavily on facility fees as part of their charges to patients for care. Okay, well, let's look at what happens with the first part of the annual wellness visit. This study was done long before the annual wellness visit was anywhere on the horizon. But this was a randomized trial we did of minicog screening to see whether it affected what doctors did afterward. And I can show you here. This is the part that I want you to look at right in here. 2 clinics were randomized to no screening, 2 were randomized to screening. Medical assistants were trained for about 15 minutes or less to do the minicog. They did it with high reliability. And there was a nurse champion who made sure that all the forms were submitted at the end of the day and that people were actually getting screened. We managed to screen about 70% of people that we considered to be eligible for screening in a routine visit. The screening was done prior to the physician's entry into the room, and here are the basic results. In the control clinics, if I can find my pointer up here, sorry about the wiggle. Control clinics, there was over the first year after screening in the other clinics, there was a slight bump, a tiny little bump in the number of people who had a dementia diagnosis or some indication of the doctor's awareness that dementia might be present. And then right next to that is in our experimental clinics, people who weren't screened essentially fared the same way. No increase in diagnosis. People who passed the screen, no increase in diagnosis. There was a nice and statistically significant bump in physician actions reflecting their understanding that patient had dementia in about 15%. That's not a very good result, really, when you think of a systems point of view, but it was a pretty nice result showing that there was some impact on physician behavior from simply doing a screen and seeing a failed screen. Then Shawn Demers, who was a fellow at the time she did this work, took a look at the people who'd failed the screen after about 5 years after failing the screen. And we can see that only about 24% of people eventually had a dementia diagnosis, and only 13% ever had anything documented in their chart that said management steps were taken of some kind. So we had a very long chart abstraction tool that we used for this study. In contrast to that, over here on the right, the bottom right panel, I do wish I had a better way to point. Sorry. Over here on the right, just take a look at the tallest of the 3 yellow bars. That's about 3/4 of people had some indication in their chart that could be indirectly linked to the likelihood of cognitive impairment. Missed visits, non-adherence to medications, unexplained weight loss, dehydration, this kind of stuff. Indirect, not proof of cognitive impairment, but indications that you ought to be concerned. So lots of people in this cohort had consequences probably linked to their screen failure 5 years earlier, but very little was done to avert this. Okay. Moving on to thinking about medical comorbidity, it used to be thought that Alzheimer patients were healthier than other people. And the reason for that was because the focus then was on Alzheimer's disease in people in their 60s who didn't have a high rate of medical comorbidity. But the average patient with Alzheimer's disease has quite a bit of comorbidity. This first study is a sample of 3,851 patients with neurodegenerative dementias who are followed in our National Alzheimer's Disease Research Centers. NAC, National Alzheimer Coordinating Center, is the data repository for all data that comes out of from volunteers in the ADRCs. It is the largest sample, I believe, in the world of people diagnosed with dementia using standardized research quality diagnoses and a uniform practice across the country. So it's a very rich and interesting source of data on Alzheimer's disease and other dementias. In this group, about 90% had at least one medical condition that had to be treated, and the ones that the centers are most interested in, of course, are cardiovascular disease and cerebrovascular risk factors, so they emphasize hypertension, dyslipidemia, cardiovascular disease, cerebrovascular disease, diabetes, and so on. But in this group of research volunteers, about 25% had 3 or more chronic conditions requiring treatment. This qualifies them for anybody's definition of multimorbidity. So even in these rarefied research environments, 25% are medically complex and have multimorbidity in conventional diagnostic terms. This is our study of 3,000 elderly people followed in Eric Larson's ACT study. As I mentioned earlier, in this study, this cohort is followed for a long period of time, and then some people will develop dementia, and they kind of peel off, and they are no longer actively followed within the research environment because this is a risk factor study. So once dementia is developed, we're not talking about risk factors for dementia anymore, we're talking about established dementia. So the people who don't develop dementia continue to be followed on in perpetuity as long as NIA funds this project, and it's been funded for over 25 years, so it's doing pretty well. Okay, in this study, 28% of people with dementia had a potentially preventable hospitalization. What is that? That's hospitalization for a condition that we believe, if it were managed well in primary care, detected early, managed proactively, it never would have gotten bad enough to lead to a hospital stay. That's how we defined preventable hospitalizations. And people with dementias in general, most of which is Alzheimer's, but not all, had about a 1.8 odds, greater odds as opposed to people without dementia of having a preventable hospitalizations. And most of them were for ordinary routine things. They weren't for behavioral problems. They weren't psychiatric admissions. They were for common chronic diseases like congestive failure, pneumonia, urinary tract infection, and almost exclusively in dementia, dehydration. Okay, we've talked about dementia detection. We've talked about medical comorbidity. Now we're moving to part 3 of the model, neuropsychiatric symptoms. which receive a great deal of attention in our own psychiatric literature. So this is the same NAC database, work done as part of her doctoral thesis by Dr. Sadak, who's here today. 40% of these patients with dementia had a depression diagnosis of some kind. They had at least one neuropsychiatric symptom 88% of the time, and we found that any symptom can occur in any dementia. Total score did vary with diagnostic subtype and complexity, and there were some differences in specific symptom profiles across subtypes using Alzheimer's as the reference. The details of this are less important than the overall fact of how prevalent neuropsychiatric symptoms are.
Sue?
Yes?
You can press A, and then you'll have the arrow.
Press A. Press A?
Yes.
Okay, and then what?
That should give you the arrow.
Where?
Try moving.
Oh, there it is. There's the, okay, well,
A is supposed to make it.
okay.
Command A.
Well, Command A, okay. Command A, okay.
Yeah.
Is it there? Okay. Oh, nice. Okay, thank you. I'm new to Mac. Okay. So we've talked about neuropsychiatric symptoms. Many of you probably hope to hear more about it than what I'm able to talk to you about today, but we can talk about it if there are questions later. Now we'll move to the fourth part, which is what about the caregivers? So typically speaking, we don't even know who's a caregiver. If I wanted to find caregivers of people with dementia in, say, our database at the University of Washington hospitals, there would be no way for me to do that. I would have to go and find people with a dementia diagnosis, and then I would have to go painstakingly through their medical records to see whether there is, in fact, a caregiver and who that person is and how I would call them if I could find them. There is no healthcare system that captures these kinds of data. We ask everybody about smoking, we ask about hours of sleep, we ask about pain, we ask about drinking and substance abuse routinely, but we never ask patients if they are caregivers for somebody with a disability. And yet being a caregiver for any kind of individual with a serious and permanent disability is a large health risk. I wish I could go into that more with you today, but I can just show you something about it, and that is that this is a very large study that I don't think was ever published, but I came into possession of this slide a long time ago in connection with another talk. This was a survey of a huge sample, over 3,000 people who were providing care for somebody with Alzheimer's disease, about their health status and about their symptoms. And what I want to highlight for you is that the largest percentage of patients, of caregivers, reported symptoms that are related to stress. Backaches, chronic pain, arthritis pain, trouble with sleep, indigestion, anxiety, and depression. So anywhere from 35 to 60% of caregivers reported one or more of these stress-sensitive symptoms and syndromes. Contrast that with high blood pressure at 32%, cancer at 6%, and then look at the right-hand column at the percentage of people with this condition that they report for which they are getting no treatment. And again, you'll see it's these stress-sensitive symptoms that are most likely to be untreated. This is a bit alarming, and so our next idea was to work on finding people who have needs that are unmet. So up in the right-hand corner is the stress thermometer. This is a cute little tool that our caregivers think is fun to use and which we like a lot. It's scored 1 to 5. 1 is very low stress, 5 is extreme stress. And our goal was to see if we could find create a simple tool that would help primary care find people who needed something beyond what they had. And we used a wide range of data and regression analyses, and what came out was that there were 2 major predictors of unmet need for services. The first is moderate to high stress. In our sample, 60% of the caregivers had moderate to high stress. In the Alzheimer's Association national sample of caregivers, 60% have moderate to high stress. The second predictor was a short list of patient behavioral problems: agitation, aggression, psychosis, profound apathy, and the like. A short list of behaviors, 5. A stress thermometer, 1 question. Together accounted for 10 times the amount of variance in unmet service needs as all other measures combined. Powerful. I'm going to skip this slide because it's really hard to understand, but it just, I'll tell you that this really looks at care from 2 points of view. One is kind of physician, medical type care, and the other is psychosocial care management, the kinds of things that social workers would typically do in dealing with families coping with dementia. And we have stress and behavior kind of combined here. Don't trouble yourself to really understand it. But I do want to say that this allowed us to select cut points. How much stress, how much behavior does it take to put a dyad into this high needs group? Unmet service needs, both medical and psychosocial. One of the key findings from this study is that caregivers themselves look at their own doctors as people who need to help them with caregiving. It isn't how the doctors look at them, but they look to their doctors to help them with caregiving. It goes without saying that most doctors do not have psychosocial care managers available to them with any ease. So coming back to our integrated dementia care idea, I'm going to ask you to help me here. I want you to tell me, how could we use a model like this to manage Joe? Let's say even from the time before his wife died, but at least starting with when his wife died. Please, help me out here. Can we use a model like this to help him?
Annual mini-cog?
Okay, an annual mini-cog. He could participate in the annual wellness visit. And maybe he passed the first year, or maybe he didn't. But once he's failed, you probably do want to check up, and you have to follow up and do more to figure out what's going on. But that's the beginning point, okay? Then what else would we do for Joe? Yeah, Paul.
Should we just back up a little bit and say, don't we have to promote the idea to elderly folks who are older that being screened for dementia is okay?
Oh.
And that it isn't, that there's things that can be done for them perhaps, and it's not a stigma, and that they won't be dropped from all medical care or dropped in the family,
right.
that sort of thing.
Okay, actually that question has been answered. In our own randomized trial, we had greater than 90% acceptance among the people that the medical assistants actually approached to screen, and that a large state of Wisconsin has done a large mini-cog screening project in which they found 96% acceptance of the screen, this particular screen. So I think this idea of stigma, I mean, although it still pervades some sectors of the profession and some sectors of the population, and I don't want to diminish the importance of that, dementia is becoming destigmatized, and one of the ways that we can destigmatize it is look at it as a manageable condition, right? Okay. So what else can we do for Joe? Yes, Karen.
Somehow involve the family earlier or identify
Yeah.
the family and get them, oftentimes they need to go to visits.
They do need to go to visits, and the shocking statistic is that most people with dementia, earlier stages of dementia, go to doctors on their own. And they don't know their medicines, but they know that they're doing what the doctor says they should. Okay, well, I'm going to make it easy for you. Let's think about what happened to Joe when the bottom fell out and the catastrophe hit. What happened to Joe was this. He was gradually and quietly dementing. His daughter was preoccupied with her own stresses. She loved her dad. She really wanted to help him, but she didn't know what to do. She'd already told the doctor that she thought he was having a memory problem, but the doctor said, he looks really good in the office. I think he's okay. And so what happened in June, when his blood pressure was out of control, unbeknownst to the doctor, was that he'd stopped taking his lisinopril because he had run out of it. And so the doctor added a drug when he wasn't taking his basic drug. And he added a diuretic. And what did we know about summer in Seattle this year? It was hot. It was hot, hot, hot. Very, very gradually, Joe began to dehydrate. He was taking a diuretic. He was trying really hard. He didn't have a lot of thirst. He didn't really know that he should be drinking. Water wasn't medicine in his book. It is in mine when I work with Joe and other Joes. So he got very dehydrated in August when we'd had weeks of extremely hot temperatures. And that is what happened to Joe. Joe fell down and broke his hip. Never mind that he got rhabdomyolysis, that he was not only severely dehydrated and had an E. coli urinary tract infection and had rhabdomyolysis and was in grave danger at the time he arrived in the emergency room. But that is how this all came about. And this is the scenario that's repeated time after time in emergency rooms everywhere. We could talk more about Joe, but let's don't for now. Well, what about this model? Has anybody really tested this integrated model? And the answer is no. The closest that we have come in the research arena to testing a model like this is really to bring in kind of some psychosocial care management into primary care. And some very fine work has been done at other institutions to do this and have shown that you can get some improvement in behavioral symptoms reported by caregivers and some reduction in caregiver stress. None of the existing models incorporate all 4 parts. They don't deal with medical comorbidity in a systematic way. And what I'm arguing today is that every person with dementia can be profiled, bad word, but that's the word that comes to mind, along these 4 dimensions at the time that their dementia is detected. And there are lots of ways of thinking about this. There's a lot of deep knowledge that would have to go into generating these profiles, but all that deep knowledge can be turned into a usable set of tools for primary care practice. That's certainly the case. So all we've been able to do so far with our little model of 4 parts is to think of it as a medical home. This is a medical home for dementia. We did track it in an observational intervention study of a small group of dyads dealing with dementia, and we were able to reduce at least 1 hospitalization by detecting the cause of it before the patient was delirious. We also were able to get a man who was like this in the clinic to sit up and talk to us when we talked to his cardiologist and got him to stop over-treating the hypertension. So we have tantalizing little tastes of how individualizing a profile across these dimensions can really help manage dementia over the long term. So if we had done this with Joe, we've talked a little bit about it, his dementia would have been diagnosed early. He would have had a comprehensive profiling assessment across these dimensions. The family would have gotten involved much sooner and much more, and would have been welcomed in the healthcare environment. Systematic monitors for medical status, neuropsychiatric symptoms, and family stress could have been put in place. Proactive primary and psychosocial care could have been integrated, and supportive home care could have been brought to bear when and how it was needed. And that would have stopped the entire process. This process cost the healthcare system at least $100,000. What happened to Joe? How much would it have cost to do this? So I want to thank a really large number of incredibly wonderful people who have helped develop these ideas with me and have participated in various studies. And I also very much want to thank everybody who has come through our clinic to be trained and who have found it very difficult to tolerate this kind of training and to think this way because it's so complicated and takes so much time. But all those people have helped me to put all this in words so that I can say it to you. So thank you very much. Richard.
So I'm going to respond to your question. And you used the expression, or your question of, could this be done in our current healthcare system?
Yes.
And just before you said medical home, I said what you're describing is a medical home for comprehensive integrated care for the constellation of issues.
Yes.
Clinical, comorbid, social.
Yes.
So one of the challenges, of course, it's a perfectly wonderful model, it's a good vision for us, is that there's not a home yet in the healthcare system in America to the residents for this care delivery system. And because, as you know, the dementia experts who often are neurologists and psychiatrists don't either see themselves or have the full complement of resources. The primary care system is, even if they are inclined to want to provide it, are often not resourced or trained to do it.
Absolutely.
One of our challenges is going to get these two things to map and overlap, right?
Yes, it is. That's the challenge, is the dementia-capable workforce and how that should be put together. I believe that it can be put together with relative simplicity at the conceptual level. One of the things we're trying to do in the School of Nursing is develop a curriculum for advanced practice nurses and DNP students, and ultimately later for undergraduate nursing students, so that they will become familiar with this and they will see it as something that attracts them rather than something that drives them away. Those of us who trained a long time ago know about GOMERs. We have too much respect for our patients now to ever refer to one as a GOMER. What is a GOMER? It's an old guy just like Joe Bailey, and we want to say to him, get out of my emergency room. That's a GOMER. And so there's still a lot of fear of dealing with something like this because it's such a complicated task. But we've learned from psychology that you break complex tasks down into simple parts, and then you can make progress. Anyone else?
I think the other point you made was in the annual visit was an example of reimbursement change.
Yes,
in healthcare,
right.
Incentives for systems to move in this direction.
Incentives through the annual wellness visit. There's also an incentive to deliver high-quality dementia care that may not outlast 2010. But that, and I didn't talk about that, but the AMA's new 10-point indicators of high-quality dementia care to be applied in audits to healthcare environments. 9 of these have been accepted by CMS as valid quality indicators, which if a physician or practice meets these quality indicators, there is significant reimbursement incentive. So the one, interestingly enough, the one of the 10 that was not included in what was approved by CMS so far is early initiation of palliative care. And I think you can all guess why that's true. Death panels loom large. But what is meant, of course, isn't hospice, but a palliative approach to chronic incurable disease. Thank you.
Wonderful.
Thank you.